Practices are closing down because they're too busy.
Some of them are just saying, well, we'll see our normal patients, but if you have a compensable injury, you have to go elsewhere.
We're here today at the PIEF 2025 National Conference, and Stephen and Hugh, you're speaking today?
That's right.
Yes.
So we're keen to explore how the compensable schemes can better interact with the primary healthcare industry.
Okay, so explain that to me. So if I said to you, what is the problem and what problem are you trying to solve?
So Steve is a current, very experienced practicing GP.
Yeah.
And I come from 40 years of consulting as a GP and a sports physician. And then I've gone into to work for WorkSafe and recently for TAC, and seen a real disconnect between the life and the professional space I worked in my medical practicing life and how the schemes deal with the practitioners.
Now, I have been in the scheme for only a mere 22 years. I'm sure you've been exposed to it a lot longer than me. Hasn't this always been a problem? Like, this is not new, is it?
Of course. No, it's not new. I guess you've got to remember that general practitioners see a large swathe of compensable medicine.
Yes.
And
is it getting worse or bigger?
Oh, it's getting worse. Well, I think access is getting worse.
Okay, right.
So I think there are fewer GPs per
Yes.
head of population than there was.
Yeah.
The level of care is expected to be much higher. The level of referrals has dropped down. So the amount of granular detail and information about each individual patient is now way above what it was when we started medicine.
Yeah, okay.
So our job has, in fact, become much harder.
Yeah.
So for each patient now, we are much cleverer and much smarter because we drill down into them much more. And so when a compensable patient rocks up, we need to do the same thing. We actually care about our patients.
Absolutely.
We care about their natural history. We care about their recovery. We want them to be both physically and psychologically better when they leave than when they come in. And so the compensable patients are just another patient in that space, but not quite the same workflow. So there's added stuff in the certificate of capacity, the communication with the workplace, the follow-up with the workplace, with the rehab providers and with the insurance companies.
Yes.
So suddenly you've got a whole dynamic which is completely different to the standard general practice patient, which is either privately billed or through Medicare. So, and that needs to be appreciated, that it's different. It's a different style.
And how's the medical fraternity responding? So what are you seeing, given that already I don't have time to see my patient to the degree I want? Now I've got this extra load, and which to me is increasing constantly.
So I'll give you the tip.
Yeah.
Practices are closing down because they're too busy. They have too many patients.
Wow.
And they can't make the numbers work, and they can't get enough doctors to do the proper work. So they prefer to close down, and the individual doctors, who are all independent companies, they're all tenant doctors, independent companies. They're not employed.
Yes, that's right.
So they're not employed by the practice. They subcontract to the practice. They're happy to move and go to a different site, practice their craft, but the practices themselves are closing down because they're too busy. What a shocking business model.
Yes,
shocking.
Terrible.
And one of the other reactions is that as they're approaching that threat, they'll say, well, the more difficult and complex stuff, the cases that they see will be the compensable patient. And so some of them are just saying, well, we'll see our normal patients, but if you have a compensable injury, you have to go elsewhere.
Yes.
And that's a terrible situation that the system creates. So what?
Compensable medicine cases are really interesting. They're high level, in depth, really complex. They're very challenging academically, but there's a certain personality in the doctor that's necessary to treat them well.
Yes.
And a lot of doctors, through access pressures and financial pressures, can't seem to create space to take that time to analyze properly and to do the job properly.
And
what
so
do you
what
see-
we would like to
Yes,
do.
that was
that's-
great segue.
So,
yes.
Yeah, what would we would like to do if the broad range of GPs are seeing, and perhaps we need to extend it to talk about physios and other primary care practitioners, if they're seeing just a small number of compensable patients who are complex and they tend to disrupt their daily workflow because of that complexity, perhaps we need to create a specialised cluster of those primary healthcare professionals who not only like compensable patients because of the challenge and the fact that if they do it well, it can really make a difference. How do we then give them the skills and the knowledge and support them in the way they structure their daily workflow? And I think we can do that to make the care for compensable patients easier for them, but also more attractive to do. And it doesn't necessarily simply come down to paying more money. I think it's supporting them with skills and knowledge, attracting them into some training programs in some way that are not too arduous and fit with their needs. We provide them the CPD points, but also are there ways that we can invent to make it more attractive for a cluster of our primary care practitioners to do it better? And I think it's not just about money, but there are other things that we can do to support them. And I think that's what we need to work together with the compensable schemes to hear what will make life easier for the GPs or the physios who are doing a lot of this work to attract them to do more.
And to identify that subgroup, that craft group who are interested, so that then industry and the insurance industry and the employment industry both can therefore select them out and use those practices and those interested clinicians rather than just going to the local doctor and getting taken care of. And ideally with better outcomes, better earlier return to work, rehab starting at the time of injury, no delays.
Yes.
You know, the normal things that we
We'd love to
literally,
do.
we just, it rolls off the tongue, doesn't it?
Yes, yeah, absolutely.
What's the delay between seeing a clinic, or what's the delay to see a doctor first? And then what's the further delay to see a physio? Right? Though that can be a week.
That's right.
You're a week down the track of an injury before there's any therapy.
And what
And we
strikes me in the industry,
learned yesterday, just to pick up on
Yes.
that point, that the longer that delay, the worse the outcome.
That's right.
and what I've always found in the industry, we talk about weeks as if they're confetti, right? Whereas when you talk about taking a week off work for annual leave, that's a big deal. That's a really good break. When you talk about a week delay between, an injury and an appointment, or
No,
2 weeks
it's
or 3
no,
weeks or
so
4
you've
weeks.
it's a disaster.
It's a
It's
disaster.
You've
Yeah.
got back pain, so you lie in bed and don't move because when you move, it hurts. And no one's told you, well, you've actually got to start moving.
That's right.
Because that's
That's
part of
right.
your
That's part
recovery.
of
All of
recovery.
those little things in the delay. But I think we need to hone into why has the system then been made so complicated for GPs, for physios? I just think that the schemes have built and been built on a lack of trust towards these primary healthcare, and also towards most deliverers of healthcare, with a view to being careful about and cautious about cost and cost containment,
Yes.
over servicing.
Yes.
And these have dominated the way the schemes deal with the practitioners.
Yes, yeah. So, light at the end of the tunnel?
Inevitably there is. I think Hugh's right. I think we need to create a further education scheme that's rewarded, and rewarded both in quality work, perhaps in money, certainly in kudos and further education. to get orientated doctors, and it is attractive work if it's sold properly, to then doctors and other clinicians to then engage appropriately with the employment industry, with the workforce, as well as with the insurance industry, to get a flow which is smooth and not broken, not staccato, and not overwhelming. It's often seen as an overwhelming task to see a workers' compensation case.
Yeah. And so the answer is to stop looking at trying to educate every GP and every physio in this space. They do need some basic knowledge about the certificate of capacity, but create that workforce within the workforce that where trust exists.
Yes. Excellent. Well, thank you so much for your time today. Thank you for the presentation. I'm sure it will go down very well, and enjoy the rest of the conference. Thank you so much.
Thank you so much. That's great.